From Neural Newscast, this is Operational Drift, a study in how and why intelligent systems lose alignment.
On September 5th, 2017, a STAT investigation described hospitals telling patients Watson for Oncology was like a worldwide consultation, even though the system's treatment recommendations were trained by a couple dozen physicians at a single United States hospital. That one sentence changes what the product is. This show investigates how AI systems quietly drift away from intent, oversight, and control, and what happens when no one is clearly responsible for stopping it. I'm Victoria Quinn.
I'm Thomas Crane.
This is Operational Drift. I have been trying to figure out when decision support becomes something else. Not officially, not in a press release, but in the day-to-day way a hospital understands a machine's authority. Because in this reporting, you see doctors describing Watson for Oncology as if it is pulling from the world's oncology expertise. And you start wondering, what did they think they bought? STAT says it examined Watson for Oncology's use, marketing, and performance in hospitals across the world, from South Korea to Slovakia to South Florida, interviewing dozens of doctors, IBM executives, artificial intelligence experts, and others familiar with the system's underlying technology and rollout.
That is the signal. Hospitals describe it as global. But the reporting says the recommendation logic is trained by a small, specific group. If that is true, then the product is not world knowledge. It is a portable institutional preference. So the first question is simple. What exactly is Watson for Oncology doing when someone clicks the button?
Here is what I cannot get past. The mechanics are described pretty plainly. Watson for Oncology uses a cloud-based supercomputer to digest massive amounts of data, from doctors' notes to medical studies to clinical guidelines. But its treatment recommendations are not based on its own insights from those data. They are based exclusively on training by human overseers who feed Watson information about how patients with specific characteristics should be treated. And in this case, those overseers were described as a couple dozen physicians at Memorial Sloan Kettering Cancer Center in New York. They were empowered to input their own recommendations into Watson, even when the evidence supporting those recommendations is thin. So when IBM marketed Watson as a system that could sift through reams of data and generate new insights, the reporting says that was an overreach. It does not create new knowledge. It is artificially intelligent only in a rudimentary sense. And then there is the perception problem. STAT describes a visit to Jupiter Medical Center in Florida, where nurse Jean Thompson spent about 90 minutes a week feeding data into the machine. She clicks Ask Watson, and in one example, it recommended a chemotherapy regimen the oncologist had already flagged. The doctor there, Sujal Shah, said the background information Watson provided, medical journal articles, was helpful. It gave him more confidence, but it did not directly help him make the decision and did not tell him anything he did not already know. So the value proposition quietly shifts from breakthrough discovery to a very expensive research assistant.
But IBM is selling it into clinical care. Hospitals pay per patient, $200 to $1,000 per patient, according to Deborah DeSanzo. If the recommendation is basically the training data from Memorial Sloan Kettering, and the interface also searches published literature to provide studies, then the system's authority comes from the branding of intelligence, not from a demonstrated ability to improve outcomes. Someone made the decision to ship it broadly anyway. The question is, who is accountable for proving it helps before it becomes normal clinical workflow?
This is where the story starts to feel like operational drift instead of product disappointment. The reporting says there is, by design, not one independent third-party study examining whether Watson for Oncology can deliver, and that IBM has not exposed the product to critical review by outside scientists or conducted clinical trials to assess its effectiveness. And then there is the regulatory condition underneath it. Yoon Sup Choi, described as a South Korean venture capitalist and researcher who wrote a book about artificial intelligence in healthcare, said IBM is not required by regulatory agencies to do a clinical trial in South Korea or America before selling the system to hospitals. So the product can be deployed, and the question of safety and efficacy becomes optional. Pilar Osorio, a professor of law and bioethics at University of Wisconsin Law School, is quoted saying Watson should be subject to tighter regulation because of its role in treating patients. That ethically and scientifically, you should have to prove safety and efficacy before you can just go do this. Dr. Andrew Norden, described as a former IBM deputy health chief who left the company in early August, dismissed the suggestion IBM should have been required to conduct a clinical trial before commercializing Watson, comparing it to the lack of a randomized trial of parachutes for paratroopers. When I read that, I stopped. Because that is not a fight about statistics. It is a fight about what kind of product this is supposed to be. Is it a medical intervention, or is it just bringing the best information to bear, which sounds like something that does not need proof?
And it also shifts liability. If IBM says it is not a medical device in the sense that demands trials, then responsibility moves to the hospital and the physician. But if the hospital believes it is a worldwide consultation or global, then the physician is being asked to rely on a machine whose actual epistemic source is a narrow group of trainers. That explanation does not account for the confusion described in the reporting. Confusion is not a side effect. It is a governance failure.
The reporting gives us very specific examples of that confusion. At Jupiter Medical Center, the medical director of thoracic oncology, K. Adam Lee, described it as like another consultation, but it's a worldwide consultation. And an oncology nurse, Carrie Ward, talked about it pulling from 300 journals, and then noted Sloan Kettering is feeding the clinical information. Robert Garrett, the chief executive officer of Hackensack Meridian Health, using a version of Watson for oncology, described the information in Watson as global, saying, as he understood it, it included how colon cancer is treated around the world by different clinicians and what has been most effective. And then the reporting says, none of that accurately depicts how Watson for oncology works. It says the recommendation itself is derived from the training provided by Memorial Sloan Kettering doctors, not from the outside literature. The literature appears as support, but it is not what generates the recommendation. Memorial Sloan Kettering doctors acknowledge their influence. Dr. Andrew Seidman, described as one of the hospital's lead trainers, is quoted, "We are not at all hesitant about inserting our bias," calling it a very unapologetic bias. He says they keep training grounded in clinical evidence when it exists, but they give recommendations when it does not. STAT also describes a training session where Memorial Sloan Kettering doctors and IBM engineers debated how to categorize options: green, orange, red, in scenarios where evidence is weak. Dr. Marisa Kohlmeyer is quoted saying, "This is the hard part of this whole game. There's a lack of evidence, and you don't know if something should be in green without evidence." And then they had to press ahead anyway, because the system requires them to press ahead. It does not learn from patient outcomes, whether people lived or died or survived longer. It learns the preferences of the physicians training it.
So the drift is not that the system became biased. The drift is that bias became a product feature, but marketing and adoption language treated it like neutral global intelligence. And then you get international friction. Researchers in Denmark and the Netherlands told STAT hospitals had not signed on because it was too focused on the preferences of a few American doctors. In Denmark, an unpublished study had about a 33% rate of agreement, and the hospital decided not to buy the system. Those are not abstract complaints. That is a measurable mismatch between what the system says and what local doctors do.
The research base around Watson for oncology, as described here, is also narrow in a particular way. The reporting says the only studies about Watson for oncology are conference abstracts. Full results had not been published in peer-reviewed journals. And every study, save one, was either conducted by a paying customer or included IBM staff on the author list, or both. Most of those studies are concordance studies, Watson gives recommendations, and researchers compare them to what oncologists recommend. But the reporting notes the limit. Showing Watson agrees with doctors proves only that it is competent in applying existing methods of care, not that it improves them. And then there is the deployment condition again. Once hospitals are using it, Choi suggests a clinical trial becomes too risky because marginal benefit would be bad news for IBM. So you end up in this loop where adoption makes rigorous evaluation less likely, and lack of rigorous evaluation does not stop adoption. There is another kind of drift here, the interpretability failure that shows up as clinical confusion. In South Korea, Dr. Tae-woo Kang said Watson sometimes recommends a chemotherapy drug called a taxane for a patient whose cancer has not spread to the lymph nodes, even though he said that therapy is normally used only if it has spread. And then Watson will show a study supporting the taxane, but the study is about patients whose cancer did spread to their lymph nodes. Kang is left confused about why Watson recommended it, and Watson cannot tell him why. That is not just an agent experience problem. In medicine, why is part of safety.
And the accountability gap widens when you add localization. IBM said the system can be customized for variations in treatment practices, drug availability, and financial considerations. But one manager in Thailand, Nan Chen, described doctors saying, essentially, they already know their own treatments and do not need to teach Watson so it can tell them what they just taught it. Yet Chen also described a hospital in the capital of Mongolia, UB Songdo Hospital, with 0 oncology specialists following Watson's suggestions nearly 100% of the time. So the same product can be redundant in one place and functionally decisive in another. If that is the case, then who owns the risk where the tool becomes the specialist?
I keep coming back to that because IBM's stated goal here is to democratize medical knowledge so every patient can access the best care. And you can see why hospitals would want that. Some doctors described concrete benefits, saving time searching for studies, educating patients, undercutting hierarchies. But the system's recommendations are described as trained preferences from Memorial Sloan Kettering, not outcome-learned patterns from global patient data. And the reporting says IBM has not published scientific papers demonstrating how the technology affects physicians and patients. So when Watson is placed in a room with 5 doctors and a screen, as described at Gill Medical Center, it is not just presenting information. It is reshaping the human process of decision-making. And yet, the evidentiary burden for whether it improves care is not clearly assigned to anyone.
The unresolved question is not whether Watson for oncology is useful sometimes. The unresolved question is whether a system can be deployed into treatment decisions, while independent evaluation remains optional, and whether anyone can be made responsible for that choice. Operational drift is not the moment a system makes a bad recommendation. It is the moment the system's authority expands, while the obligation to prove safety and efficacy dissolves into marketing language, conference abstracts, and local customization. Sources and our transparency policy are at operationaldrift.neuralnewscast.com. This episode is based on referenced source material and is not medical advice. Do not make medical decisions based on this program. Neural Newscast is AI-assisted, human-reviewed. View our AI transparency policy at neuralnewscast.com.
This has been Operational Drift on Neural Newscast, examining how and why intelligent systems lose alignment. Neural Newscast uses artificial intelligence in content creation, with human editorial review prior to publication. While we strive for factual, unbiased reporting, AI-assisted content may occasionally contain errors. Verify critical information with trusted sources. Learn more at neuralnewscast.com.